This is how I interpreted this ECG as a paramedic. This one looks a bit mental, so let's get into it. I'll be honest, I'm totally distracted by these broad and sometimes irregular QRS complexes, so I'm going to tackle these first. I initially thought these irregular beats were premature ventricular contractions, or PVCs, which occur when the ventricles fire off random impulses outside of normal conduction. But on closer inspection, I could see P waves before the complexes, so it looks like the atria have likely initiated this premature beat. So these must be premature atrial complexes, not PVCs. The other complexes look broad too, making me think that there may be a bundle branch block at play. I like to use V1 and V6 when checking for bundle branch blocks. Changes do occur in other leads as well, but I'm a simple creature, so I mainly focus on these two leads. The QRS complex looks borderline broad, and the width calculation reads 120 milliseconds, which is right on the cusp of bundle branch block criteria. The QRS complex is negative in V1, not positive, and although there's some poor voltage in V6, the R waves do appear broad and I can't see any Q waves. So this to me looks like a left bundle branch block, or at the very least an incomplete left bundle branch block. I've also noticed that the P waves look quite far away from the QRS complexes, but they do seem to be regular. So I think we also have a first degree AV block here as well. I'd probably document this ECG as sinus with first degree AV block, left bundle branch block, and frequent premature atrial complexes. This is how you can assess the cardiac access quite easily on an ECG. So pay attention to leads 1, 2 and AVF. If the QRS complexes are mainly upright in these leads, then you have a normal cardiac access. If the QRS complex is mainly negative in lead 1 and positive in lead 2 and AVF, then you have right axis deviation. If you think right for reaching. If the QRS complexes are mainly upright in lead 1 and negative in lead 2 and AVF, then you have left axis deviation. Remember, left for leaving. And if the QRS complexes are all facing mainly downwards in 1, 2 and AVF, then you have extreme axis deviation. So with that in mind, calculate the cardiac access on this ECG. We have left axis deviation because the QRS complexes are mainly upright in lead 1 and negative in lead 2 and AVF. Now calculate the cardiac access on this ECG. Here's lead 1, 2 and here's lead AVF. So 1, 2, AVF. We have a normal cardiac access because we have an upright QRS complex in lead 1, lead 2 and lead AVF. Now give this one a go. Can you see left, right or a normal cardiac access? So this is a right axis deviation. It's a little bit harder to understand why, because this lead has an equiphasic lead, which means the QRS complex is both pointing upwards and downwards equally. So what we do then is we miss lead 2 out and we go straight to AVF, which is mainly upright. So because the QRS complex is mainly negative in lead 1 and mainly upright in AVF, we have right for reaching right axis deviation. If my crewmate handed me this ECG, here's how I'd interpret it. First, I'd cheat and look at the rate calculation. I'm not doing maths if I don't have to. I'd then check to see if the rhythm was regular, which it was, and check to see if there were P waves before each QRS complex, which they were. P waves were also upright in leads 1 and 2 and negative in lead AVR. And when all these features are present, you can spot the rhythm as sinus. I then look to the QRS complexes of leads 1, 2 and AVF to check the cardiac access, which I can see is normal because all the complexes are facing upright. Then I'd move on to the PR and QRS intervals. The PR interval is normal because it's between 120 to 200 milliseconds, and the QRS width looks, actually with this M-shaped QRS complex in V2, it looks a little right bundle branch blocky, but the interval is less than 120 milliseconds, so it's not quite wide enough for it to be a complete block. So I'd refer to this as an incomplete or partial right bundle branch block. Next, I'd move on to the ST segment and T waves. Specifically, I'm looking for any abnormal ST depression, elevation or T-wave inversions. But other than some T-wave inversions in AVR and V1, which is normal, there's no issues I can see with this segment. The last thing I'll do is glance at the QTC interval to make sure it's not prolonged before documenting my findings on my paperwork. For this ECG, I'd probably document it as sinus rhythm with an incomplete right bundle branch block.